Hello, I'm Ginger Krawick, Director for Health Professional Training and Cancer Control at Your American Cancer Society. For more than 60 years, we've provided grants to oncology social workers, nurses, and physicians to assure that the quality and quantity of cancer health professionals remains strong. The strength of professional practice, however, does not just depend on having enough smart people on the ground. Clinicians need the best tools possible to do their important work, and over time, research has provided more effective tests, treatments, and interventions. Conversely, clinical practice constantly highlights where more knowledge is needed to improve outcomes for the public and for persons with cancer. Today, I am delighted to introduce Dr. Karen Kayser, who will share her perspective on the critical interconnections between practice and research. Dr. Kayser is the 2012 recipient of the Association of Oncology Social Work American Cancer Society Quality of Life Award. She is Professor of Social Work at the University of Louisville and holds the Dr. LaRocca Endowed Chair in Oncology Social Work, which is the first such chair in the world. Dr. Kayser received her master's degree in social work from the University of Michigan, specializing in practice with children and families. She then pursued her doctorate, obtaining a degree in social work and social science, and embarking on her research career. Over time, she has contributed greatly to knowledge about how couples respond to a cancer diagnosis and interventions to assist them in coping. I know you will enjoy Dr. Kayser's presentation, Building Bridges Between Oncology Social Work Practice and Research.
Thank you, Ginger, for that introduction, and also thank you for the opportunity to be here today to present the American Cancer Society Quality of Life Award lecture. My experience with chronic life-threatening illnesses began when I was 6 years old. As a child, I suffered for months with excruciating pain that neither pediatrician nor my parents could figure out how to relieve. My pain spread to my family as they carried the emotional burden of watching my suffering. It was only after becoming so ill and near death that a perceptive urologist discovered that I had kidney stones. Over the course of the next 3 years, I had 2 surgeries, spent 4 weeks in the hospital, and afterward lived with extensive dietary restrictions. The most memorable experiences during my ordeal were my hospitalizations. Now, back in those days, during the late 1950s and 60s, your hospital room looked something like this. It was a large room with about a dozen young children, ranging from toddlers on up, and our beds were kind of cage-like. The floors were tiled and cold, and no pictures hung on the wall. The worst part were the limited visiting hours for parents and no visiting by children under 13. My 2 siblings, both of them who were a few years older than me, never visited me in the hospital due to that. The playroom was empty except for, I remember, one checkers game. So my father taught me how to play checkers, and we must have played hundreds of games while I was there. This photo in the slide is the actual playroom of my hospital after the playroom was remodeled. As you can see, they added a doll and a rocking horse. During the 1950s, the medical profession was treating diseases and not people. They focused on a person's physical pain and not their emotional and social pain. It's not too surprising that when I grew up, I had really no interest in pursuing a medical career. I hated a hospital, but I wanted to help people with their suffering, either emotionally or physically. This desire led me to study social work and launch a clinical career focusing on mental health, children, and families. It wasn't until later, when I was working on my PhD, I worked as a social worker at the University of Michigan Medical Center, and then after graduating with my PhD, I had an opportunity to do a postdoctoral fellow on a clinical research project working with families in childhood cancer. In his recent book, The Emperor of All Maladies, Mukherjee details the history of cancer and how back in the time when I was a child, cancer was considered a terminal disease for most children who had the diagnosis. With research and new treatments, the survival rate has risen beyond 80% for most cancers and even higher for certain others. In a similar vein, our psychosocial care of patients has advanced. Children are not housed in large wards with little social contact and no toys. Counseling and support groups are common, either in hospital or community-based agencies. But in other respects, the advances in medicine have presented new challenges to delivering psychosocial care. For example, consider the burden of care that short-term hospitalizations place on families, and the complexity and complicated treatment protocols that caregivers must learn to provide. Technology that allows patients to continue living even though their quality of life is compromised and death is inevitable. Something that I refer to as high-tech, low-touch dying. Consider the impact that medical advances have had on the affordability of healthcare. Medical expenses are the #1 cause of bankruptcy for families. The cost of medical insurance has increased 100% since the 1950s, and 49.9 million Americans do not have health insurance. While advances in research and in the field of medicine have rapidly changed healthcare over the past decades, research in advancing psychosocial care has not kept up. Hence, it's not surprising that the Institute of Medicine's report on cancer care for the whole patient concluded, cancer care today often provides state-of-the-science biomedical treatment but fails to address the psychological and social, that is, the psychosocial problems associated with the illness. Dr. Mukherjee makes a similar point from a physician's perspective when he quotes June Goodfield. Cancer begins and ends with people. In the midst of scientific abstraction, it is sometimes possible to forget this one basic fact. Doctors treat diseases, but they also treat people, and this precondition of their professional existence sometimes pulls them in two directions at once. Oncology social workers have had to adapt and respond to a rapidly changing medical environment. In keeping up with these changes, medical social work research has focused on validating what oncology social workers do, making decisions regarding best practices, improving psychosocial care with cancer patients with an emphasis on social justice and equity. However, I propose that social work practitioners and researchers together need to be more proactive, and in the coming decade will need to transform practice to meet the current needs of patients and families and the new standards of care. We need to do more than merely validate what we do. We need to show that our work adds value to the care of patients and, at the same time, reduces medical costs. We need to study our social work interventions in determining what are the best practices in providing care to all patients. What I am proposing is that we need to think differently about how we do our research and ultimately our practice. New paradigms for research are needed in order to address these new challenges. To keep up with rapidly changing medical systems and advances in medical technology, our psychosocial research has to be transformative. By transformative, I mean our research should produce second-order change, that is, change on the systemic level. And it must be innovative, that is, not more of the same, but advancing our knowledge. So, how do we use new research paradigms to transform our social work practice and policies? How can practitioners participate in our research endeavors? I'm suggesting that we cannot move to this level of change until we start changing the way that we do our research. To do this, research needs to be translational, transdisciplinary, and transnational. First, starting with the translational research, We mean bridging science and practice. This type of research developed from an awareness that just producing research doesn't mean that practitioners are actually using research results in their practice. Translational research aims to apply scientific knowledge to meet a particular need or address a problem. It's composed of 3 levels. First, we have the basic, or what we call bench research. Then we have applied, or bedside research, and then dissemination, or trench research. And in this figure, you will see that each box is the same size to indicate that none of the boxes is more critical than any other. All 3 are needed to maximize the impact of psychosocial research into the cancer community. Now, basic research helps us to understand basic behavioral and social phenomena related to the cancer experience. This type of research explains how certain individual or social factors are related to cancer-related outcomes, such as quality of life, access to medical care, adherence to treatment. It can focus on individual levels, like, for example, looking at a patient's decision-making process about treatment, or it can focus on an organizational or community level, for example, access to palliative care in a rural community. It also includes biopsychosocial research that looks at how genetics or immunology or cognitive neuroscience interact with health and health behavior. An example of basic research is a study that I conducted with the social workers at Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston. And this was during the 1990s. As usual in my research, I start by asking the oncology social workers if they had any questions or issues that they wanted to study to help them to better understand their patients and their practice. They said that the patients who were mothers, especially of young children, seemed to be struggling with balancing their child caregiving and other family responsibilities with the demands of their cancer treatments. One issue in particular involved decision-making around treatment options. The social workers observed that the women seemed to be putting their children's interests before their own self-care. We developed a research protocol that included a questionnaire and interview measuring various aspects of the women's relationships, the emotional support, their coping, intimacy, etc., and well-being outcomes like depression, quality of life, and health self-care. Overall, the findings revealed the importance that mutual relationships and relational coping strategies played in women's quality of life. For example, those women who believed in silencing the self or who attempted to protect and buffer family members from their illness did not do as well on measures of depression, self-care, and quality of life as mothers who were able to assert their needs, involve family members, and had supportive partners or spouses. The next step or level in this type of translational research is called applied or bedside. It's when we apply what we learned from our basic research to practice. Hence, I used our results from the mother study to design a psychosocial intervention for breast cancer patients and their partners. We called it Partners in Coping, and its aim was to help women and their intimate partners learn to support each other and cope together with the demands of a breast cancer diagnosis and treatment. You may be thinking at this point, well, I'd like to design an intervention and apply it to my practice, but I don't have time to do basic research. Well, the good news is that you don't always have to do the basic research yourself. There may be a number of already existing studies and research that's been done on a particular topic that you're interested in, and you don't need to repeat these studies. So in these cases, what I suggest to social workers is that they start looking at meta-analyses or systematic reviews to inform their practice. For example, before developing the Partners in Coping program, I did go and look at outcome studies on psychosocial interventions to see if anyone had developed a couple-based intervention similar to what I was proposing. And there are two ways that you can gather this information. You can either search databases for all the studies that have been done, and the databases could be like PsycInfo or Medline or Social Work Abstracts, and read all the studies that you find. However, this can be pretty time-consuming if you find that there are about 50 or 60 studies that have already been done on the particular topic you're interested in. So instead, what I suggest to people is actually going and putting in meta-analysis as a key word with the thing that you're interested in. Like you could put in a keyword psychosocial intervention, and what you will come up with is a meta-analysis, a review that has already been done for you. And even if you come up with 3 or 4 meta-analyses, you really only have to read the last meta-analyses because it will include all the previous studies. So a meta-analysis differs from our traditional literature review in that it's systematic and it uses quantitative methods to analyze, synthesize, and summarize the results of a large number of research studies on one particular topic. This allows decisions to be made regarding how effective an intervention is and will suggest best practices for a particular problem. In using the meta-analysis to inform practice, the statistic that you will be interested in is called the effect size. The effect size is an index that tells you the amount of change that resulted from the intervention. Also, as a practitioner, you may want to pay attention to what we call moderating factors. These are things that affect or moderate the degree of effectiveness of an intervention. For example, I found in my evaluation study of the Partners in Coping program that younger couples benefited more than older couples in my research. Hence, age was a moderating factor. And today, the number of intervention studies is growing to the point that now we not only can answer the question, is the intervention effective, but for whom is it going to be effective? The last box in translational research focused on the phase of dissemination. As mentioned earlier, all of these types of levels of research are equally important. However, dissemination is the research that has been largely overlooked and underfunded. This is unfortunate in that dissemination is critical to linking research with practice in a broader context, that is, for use by other researchers, practitioners, policymakers, and consumers. The process of dissemination occurs in 3 ways. First, dissemination can be just diffusion, which is a passive process by which research findings are made available to a clinical audience, usually through publications like peer-reviewed journals. So if I just go publish my results, that's diffusion, but it's a very kind of passive way of disseminating my results. Dissemination, the second phase, is by which information relevant to practice is actively distributed to a targeted audience. So for example, when the National Comprehensive Cancer Network's guidelines come out for implementing, say, distress screening, that is more directly targeted to practitioners that they want to be implementing distress screening. The third type of dissemination is called implementation, and this is a more active process designed to enable healthcare providers to deliver the care in the manner consistent with the research evidence. So an example of this would be actually going out and training social workers on how to screen for distress and how to evaluate the effectiveness of that screening. I just wanted to mention a couple of helpful websites when it comes to this dissemination or research utilization. The first is a website of Cancer Control Planet, Plan, Link, Act Network with evidence-based tools, and it provides a link to a list of interventions relevant to the prevention, detection, and control of cancer. The website researchtoreality.cancer.gov also has valuable information about the dissemination of evidence-based interventions. And I also put up on the slide here a little pocket-sized book that contains commonly used research terms and helpful research and evaluation websites, and it's called Pocket Glossary for Commonly Used Research Terms. So if you cannot remember what an effect size is, you can look it up in this little glossary, and it will give you a definition and explanation of what an effect size is. One final point. Remember the double arrow that existed between the basic and the dissemination research? Researchers need practitioners as much as practitioners need researchers. And practitioners are invaluable in helping researchers ask the important questions and keep our research relevant to psychosocial care. So there may be at times when we need to go back to the basic research based on what the practitioners have observed. The second type of research that I mentioned that is transformative is transdisciplinary research, and this involves bridging disciplines. What do we mean by transdisciplinary research? Well, the term first appeared in the 1980s and probably best defined by Sarah Gellert and her colleagues as a mode of collaboration in which investigators operate entirely outside their disciplines and form a perspective of a problem that reflects the complexity of the problem rather than just a part of it. This approach has emerged from the realization that solutions to complex health problems require research from more than one discipline. Nowhere has a transdisciplinary approach been more needed in our research than on the problem of health disparities. Disparities in health continue to be a major challenge, as evidenced by our statistics. As we see in these bar charts, looking at the rates of breast cancer among African American women and white women in the United States and Kentucky because that's the state where I am working, the rate of breast cancer is much lower among African American women compared to white women in both the U.S. overall, which is the blue bar on the chart, and Kentucky, which is the orange bar. However, when we look at the death rates between these two groups, the reverse is true. Looking at, say, only the orange bar here, the Kentucky bar, we see that there's a much greater disparity between the death rates of blacks and whites. That is, the black women tend to have a higher rate of deaths due to breast cancer, even though the incidence is lower. So why do many more African Americans than white women in Kentucky die from breast cancer? Is it related to the poor quality of treatment or access to treatment? How patients make treatment decisions? Environmental stress? Social determinants like poverty, lack of education, or minority stress? Or different racial genotypes? The answers will not be discovered by using a monodisciplinary approach, but requires the expertise of researchers who can study genetic factors, pathophysiological pathways, individual risk factors, social relationships, living conditions, neighborhoods and communities, institutions, and social and economic policies. Researchers can no longer work in their discipline-specific silos, but must start communicating with each other to make research transformative. Working as a multidisciplinary team is a common practice in healthcare, but it's not a practice that is often formally taught among different professions. At the University of Louisville, social work researchers are working with a team of palliative care physicians, nurses, and chaplains on the problem of how to train disciplines to work as palliative care teams. The project, I COPE, teaches the roles and skills of palliative care from each professional perspective. It transcends disciplines in that all participants, learners, and teachers are working toward the same goal of the best practices in palliative care for the cancer patients, attending to the bio, psycho, social, spiritual well-being of the patient. Lastly, I wanted to talk about transnational research, and that is bridging cultures. In 2008, the Social Work Code of Ethics was revised to emphasize our obligation as social work practitioners to be culturally competent. It states, social workers should obtain education about and seek to understand the nature of social diversity and oppression with respect to race, ethnicity, national origin, color, sex, sexual orientation, and so on. As social workers, we have a moral obligation and daunting task to work toward social justice and healthcare equity for everyone. In the year 2000, I started taking graduate social work students from Boston College to countries of Nepal and India to study human services in developing countries. Often people would ask me, why are you traveling to these countries to study poverty when we have poverty here in the United States? And my answer was a simple, well, why not? Is there somewhere in our code of ethics or profession that says we should only care about people living in the United States? Our work has no national boundaries, and our research should not have boundaries either. Furthermore, immersing yourself in a very different culture, as you know, will teach you more about your own culture and give you a different lens for looking at your practice. The American Cancer Society calls cancer an enormous global health burden. It accounts for 1 in every 8 deaths worldwide. There was an estimated 12.7 million cases of cancer and 7 million cancer deaths in 2008. And according to the ACS, the incidence of cancer is growing at an alarming pace. Another compelling reason for transnational research is that most of all of our social science research, probably maybe close to 90%, is conducted with Western populations. However, 70% of the world's population lives in non-Western countries. So how applicable are all of our research findings on white middle-class people to the rest of the world? Some of my own research in India has included studying coping among the survivors of the Indian Ocean tsunami. This woman you see in the photo has lost all 4 of her young children when the tsunami wave hit the shore. I also have worked with studying self-help microcredit programs for widows after the tsunami. And recently I've conducted some research on breast cancer patients and their caregivers in India. Conducting transnational research can be a humbling experience. You learn quickly that your knowledge base is very ethnocentric, and it forces you to take other perspectives. For example, when I was disseminating the Partners in Coping program through a distance learning course for oncology practitioners, I was confronted by a learner in Hong Kong who often would point out parts of the intervention protocol that would not work for Chinese couples that he worked with in Hong Kong. So in frustration, I suggested that we conduct a study to examine how Chinese couples in Hong Kong cope with breast cancer. Hence, again, an example of going from dissemination back to the basic research. We did a study comparing American couples to Chinese and then added Indian couples to the sample. And there were some significant differences based on culture. And now we can design interventions that hopefully will be more relevant and effective with Asian couples. Okay, I'd like to conclude with several practical suggestions to begin this journey toward transformative research and practice. The first is to collaborate with social work academics. Find a school of social work near your practice setting that can help you with conducting your research. And remember that often social work professors are looking for these opportunities. I mean, maybe it's a junior faculty that needs to get tenure. So they're very open to opportunities to collaborate. Also, it suggests continuing education in another science, and these can be opportunities that you can do online. For example, MIT has an open university. You can go online and take any course. You don't get credit for it, but the materials, the syllabi, the lectures are all there for you. The third one is to join an interdisciplinary organization. In oncology, psychosocial oncology, we have APOS, which is interdisciplinary, IPOS, which is the International Psycho-Oncology Society, and then I have belonged to the National Council on Family Relations, which is, again, multidisciplinary and focuses mainly on studying families. Another suggestion is to take a service learning trip to a developing country. And you may wonder, well, where would I find such a trip? I would suggest probably just looking at nonprofits like Habitat for Humanity, any international nonprofit, and like Habitat for Humanity or Heifer, the International Heifer Organization. Some of these nonprofits will offer service learning trips abroad. You could do a simple thing like conducting a focus group in an underserved community, or read a meta-analysis related to a practice problem that you are having in your practice. Start a journal club at your cancer care setting. And finally, I just suggest writing down your experience, writing about your practice wisdom, developing a treatment manual or a protocol, materials for patients and families. Just, write it down. We also need to think seriously about preparing future social workers to be leaders in psychosocial cancer care. The potential shortage of oncology social workers and very limited specialized training in this area have prompted us at the Kent School of Social Work at the University of Louisville to develop a specialization in psychosocial oncology for the master's students. We are planning also to develop a postmaster certificate program in oncology social work. The American Cancer Society offers doctoral training grants to students who will be our future researchers in oncology social work. Finally, there needs to be more distance learning opportunities offered by the NASW or AOSW in schools of social work in order to disseminate our knowledge. In conclusion, a world of social work without transformative research is not going to advance psychosocial care to meet the needs of the future. Without translational research, our findings will be lost in translation by practitioners. Without transdisciplinary research, our findings will be lost in impact on complex problems. Without transnational research, our findings will be lost in relevance to diverse cultures. Without translational, transdisciplinary, and transnational research, oncology social work practice will not be transformative. Several years ago, I came across this book in a bookstore in northern India, and the title struck me as different. In the United States, we have The Joy of Cooking, we have The Joy of Sex, but I've never seen a book entitled The Joy of Cancer. It was written by an Indian cancer patient who told his story of transformation through cancer. I think that with a strong commitment and support from the Association of Oncology Social Work and the American Cancer Society, we can all work together to build knowledge and transform psychosocial care of cancer patients and survivors. Finally, I would like to dedicate this lecture to two transformative people who have inspired me in my career and my personal life. The first person is Dr. Mary Hughes, a close friend, colleague, and my daughter's godmother, who, while raising 6 children in the 1960s and 70s, went back to school to earn her undergraduate degree, her MSW, and then a Ph.D. in social work. Last year, 2 of Mary's children passed away from cancer. Patricia, or Trish, who was a school psychologist in Vermont, wife and mother of 3 children, died of ovarian cancer. And then Bill, her son, was a father of 2 children and a scientist with both an MD and PhD, died of lung cancer. As a scientist in the biomedical field, Bill made significant contributions to the field of antibody engineering and the development of therapies to treat cancer. Mary's fortitude, faith, and courage in face of many life adversities have been an inspiration to me. The second person is my father, who passed away this past April. He taught me that experiencing a serious illness can transform relationships for life. His career took him to over 90 countries, and his love for people from diverse nations and backgrounds inspired me to transcend ethnic, racial, and language differences and to focus on our common humanity, the common language of love that connects us to each other. Again, thank you for the privilege to be with you today.